All right, everybody, we are back at 12:35. Hope everyone got my message about lunch. So hopefully you've got something to eat in front of you, and this presentation is about ready to start. And it's on the screen there, Dr. Schiffer from Freeman West ER, talking about adult cardiac arrest. Here he is.
Hey guys, thanks for having me today. I hope the volume's all right. Appreciate you guys taking some time to listen to us today. Appreciate all you guys do. Hope you're healthy and safe. We're going to be talking about adult cardiac arrest today. I'm one of the second-year residents at Freeman. I'm probably the tallest doctor at Freeman, so there's no way you'd miss me if you saw me. So always happy to answer questions and teach you guys. I think that's everybody's job in medicine, to teach each other. So with that, I'm going to start off with a clip. Oh. Come on. Is the volume playing through this?
Start TV volume up there, Doc.
Oh.
Wait, it is up.
So is it playing through the feed?
It's the same issue I had a moment ago. Is it playing through there? It's the issue I had a while ago. I don't understand that. It is not the normal way. No, sir.
All right.
So, assessing the situation. Are they breathing?
No, Rose, they are not breathing. And they have no arms or legs.
No, that's not part of it.
Where are they? You know what? If we come across somebody with no arms or legs, do we bother resuscitating them? I mean, what kind of quality of life do we have there?
I would want to live with no legs.
How about no arms? No arms or legs is basically how you exist right now, Kevin. You don't do anything.
All right, well, let's get back to it, because you're losing them. Okay, too fast. Everyone, we need to pump at a pace of 100 beats per minute.
Okay, that's hard to keep track. How many is that per hour?
How's that going to help you?
I will divide and then count to it.
Right.
Okay, well, a good trick is to pump to the tune of Staying Alive by the Bee Gees. Do you know that song?
Yes, I do. I love that song. First I was afraid, I was petrified.
No, it's Staying Alive,
Okay, yes,
Staying
yeah.
Alive.
You were in the parking lot earlier. That's how I know you.
Staying alive, staying alive. Staying alive, staying alive.
You can't tell by the way I use my walk. I'm a woman's man, no time to talk. Words is loud, women more, been kicked around since I was born. Well, it's alright, it's okay. You can look the other way. Let it go, let it go.
Staying alive, staying alive.
Yeah, okay, you didn't maintain 100 beats per minute, and the ambulance didn't arrive because nobody called 911, so you lost him.
Okay, he's dead. Anyone know what we do next? Anybody? Rose?
I have no idea.
Anyone else?
We bury him.
Wrong. Check for an organ donor card. If he has one, we only have minutes to harvest.
He has no wallet. I checked.
He is an organ donor.
He is? Yeah. Give me some ice in a styrofoam bucket. Here we go. We search for the organs. Where's the heart? The precious heart.
I'm not feeling well. I need to sit down.
Sit down. Are you okay?
Oh my God. Oh my God.
Can you tell me why you had to cut the face off the dummy?
I didn't think it was very realistic in the movie, and it turns out it's pretty realistic.
We had to pay for it. It cost us $3,500.
$5,300 for a dummy?
Wow.
Okay, look, David, this is why we have training. We start with the dummy and we learn from our mistakes. And now Dwight.
All right, so hopefully you guys got a little bit of a laugh from that. So I thought it'd be kind of interesting to go through the history of CPR, kind of how we got here. Somewhere between the 1530s and 1800s, they would use what was called the bellows method to give oxygen to people's lungs. They weren't doing chest compressions yet. In 1775, this Danish veterinarian discovered that if he killed a chicken by shocking it, if he shocked it again, then it would come back to life. So that's pretty interesting. And then in 1874, this German physiologist doing research noticed that if he was massaging the heart during surgery, then he could get return of circulation. Another German surgeon in 1891 discovered, well, he was the first one to advocate chest compressions. In 1947, or I guess, sorry, from the 1891, even though he was talking about chest compressions, that really didn't take hold, and it was over half a century before it really did start taking hold. Open heart massage was actually the standard of care. In 1947, cardiothoracic surgeon Dr. Beck performed the first successful electronic defibrillation on an exposed human heart. And then in 1956, a couple of doctors proved that mouth-to-mouth resuscitation was an effective life-saving method. In 1957, the Johns Hopkins team unveiled the first portable external defibrillator, which is over there to the right. It looks kind of small, but it actually weighs over 200 pounds. In 1960, a group of doctors combined mouth-to-mouth breathing with chest compressions to create CPR that we kind of recognize today. In 1963, the AHA, so American Heart Association, formally endorsed CPR, and then 2018 was the latest ACLS update. So just kind of interesting to go back and see what the roots of CPR look like. So now we're going to get into the actual meat of the presentation. I know you guys all have taken, ACLS, and you guys know how to do this, so hopefully it's a good review for you, and maybe you'll pick up a thing or two. If you guys have any questions, feel free to put it in the chat, and I'll answer it as we go along. So first is kind of just the big overview slide, and there's handout cards that have this on them that I always carry around, if not on me, definitely in my bag. And I would encourage you guys to just have a printed out version, throw it in the ambulance, throw it someplace where you can easily get it, just so in some, for whatever reason you are having a brain fart or you can't remember things, it's a pretty logarithmic way of going about things, and if you follow this, you can't go wrong. So, and we'll kind of delve more. I know that's really small, so we'll delve into each of these as we go along. Obviously, the first thing you want to do is you realize somebody's in trouble. You go up to them, you check their pulse, listen for breathing, looking for chest rise. You want to do that for no more than 10 seconds. And then you want to immediately start chest compressions if that's the case. Call for help, of course, make sure the scene's safe, kind of all those basic ACLS things. So chest compressions and early defibrillations are kind of the things that increase your chance of survival the greatest. Really everything else is kind of, there's not a whole lot of randomized control trials. It's more kind of what's just been passed down and what seems to work better than other things. But definitely the compressions, good compressions, and early defibrillation, are shown to give people the best chance of survival. So your compressions have to be at least 2 inches or 5 centimeters deep, about 100 to 120 beats per minute. If you don't have an advanced airway in, then you're going to do 30 compressions and then stop and do 2 respirations and then start again with the compressions. Without the advanced airway, it's just not possible to get as much oxygen as you need in with the respirations if you don't have an advanced airway. So advanced airway means supraglottic device or an ET tube. And I know you guys have a lot of, fancier supraglottic airways. You could give a whole lecture about just all of those. They're quick and easy to put in. But those aren't definitive airways, which would be an ET tube, because that's, defined as through the cords. And of course want to minimize interruptions. And I think that's the biggest thing where us in the hospital and anyone doing CPR kind of forget about that, but really chest compressions is what's going to save their life or keep their neurological status if we are able to get them back. Make sure that you want to get IV access, but you don't want to inhibit your chest compressions. When you have that 10-second period or you have more help, then you can get your IV access. Of course, if it's not easy, you can always put in an IO. You don't want to intubate them until you get to either that 2-minute mark where you get a break, or if you have somebody that can intubate while you're still doing chest compressions. And then also when the defibrillator is charging, you want to keep doing compressions also. Those are easy places to stop doing your compressions or not doing quality compressions. And then you're going to get your defibrillator, place the pads. Here's the picture, just 2 different pad locations for the heart. Basically what you're trying to do is put the heart between the pads and deliver a shock. So I've got another video here on chest compressions.
If you see a teen or adult suddenly collapse, it's important to act fast. Helping to save a life is easier than you might think. Just start hands-only CPR.
I'll spare you guys a minute of chest compressions there. I don't know why they picked that song. It's not like anybody would have that song as their ringtone or recognizes that song, but that's what the AHA recommended. So just want to make sure you're going hard and fast, 100 to 120 a minute, and then 2 inches in depth. So after you've started CPR, kind of the process you have to go through is get them hooked up to the monitor and determine, do they have a shockable rhythm or a non-shockable rhythm. So shockable rhythms would be VFib and pulseless VTAC. Non-shockable would be asystole or PEA, pulseless electrical activity. And you can see a lot of rhythms on the monitor that look funky, but it's always important to check their pulse, because if they don't have a pulse, then it's still PEA, no matter kind of what it looks like. So just a quick rhythm review here. Here's a strip of ventricular tachycardia. Kind of that wide, so what you're looking for is wide complexes, it's regular. And the reason it's wide complex is because the focus is coming from the ventricles, which would give you a wide QRS. If it was narrow, then it'd be coming from above the ventricles. And what you're looking for is 3 small boxes. That's kind of the difference between narrow and wide. And then here's ventricular fibrillation, which is just kind of a quivering of the ventricles, no specific focus. It's not regular. It's just kind of squiggly lines. and those two rhythms are definitely shockable. You're gonna want to give them 200 joules. So you see that rhythm, you charge a defibrillator, you're doing chest compressions while you're charging it. You say, clear, everybody clears, and then you deliver the shock. Immediately after you deliver the shock, you get back on the chest, do chest compressions for 2 minutes, and then again, check your rhythm and see where you're at. In either case, once you get to that 2-minute mark, you're gonna make sure you have IO or IV access like we were talking about. You're gonna give 1 milligram of epinephrine every 3 to 5 minutes, and you'd want to give that, after your first 2 minutes is when you'd start that. And then think about their airway. Bag valves mask is kind of, the standard. You kind of don't want to give patients mouth to mouth, especially now with COVID. So we talked about supraglottic airways. You, of course, can intubate them, and typically in CPR, you want to give 100% oxygen. There's a lot of studies. You can kind of debate how good they are or not, bag valve masking versus the supraglottic or endotracheal airways.
So I have a couple questions.
Yeah.
Let me interrupt. Would that be okay?
Yeah.
Okay, so this is something that a little bit of a hot topic right here.
Yeah.
Supraglottic airways.
Yeah.
What is, obviously leading question, what is your opinion of the iGel? How familiar are you with it? At all, even?
I know what it is. I'm not super familiar with how successful it is or how successful it is compared to the other airways. I think, and that's the one where you can intubate through, right?
I've never seen it done. I've seen it in videos. It's a supraglottic airway that's a non-inflatable cuff. You just push straight in, and it seals against the trachea. And I only ask this is because as a service, I know Mets in Newton County have moved to it, but right now kind of the defining factor in our area is that Joplin Fire. We are mainly an EMT level service with 14 different paramedics, but our crews are taught to drop the iGel just immediately. Drop it immediately because you don't have to break CPR, and then you don't have to stop CPR to give a breath.
Yeah.
And it's an EMT level skill.
Mm-hmm.
So I was kind of curious if you knew a lot about it or if you had much experience or your thoughts on it.
I hadn't had much experience. I think the supraglottic airway, if it doesn't take any more time, which it sounds like it would take a second to do, then I think that's perfectly fine compared to bag valve masking. You just have to either use your finger or a tongue blade, and or just tilt their head and put it in there, and that doesn't take much effort at all. You don't have to stop CPR. So I think from that standpoint, I think that's definitely a good thing. I know with the supraglottic versus the ET tube, studies have shown not a great difference, but the people with the supraglottic airways actually had better neurological outcomes and survival than the people who got ET tubes outside the hospital.
Really?
Yeah.
That's interesting.
But I think the kind of recommendation, if they're easy to bag, and you don't have anything else with you other than the ET tube, I think the bagging is perfectly fine. You guys, it's 2 people out there going to get the patient. They're on the ground. Somebody's trying to do CPR. So if you can oxygenate them, perfectly fine with the bag valve mask. I think that's okay to wait till you get to the emergency department or somewhere else where you have one person just worrying about the airway. The patient's on a gurney. It's in good position.
Controlled environment.
Control.
Right?
Oh yeah, as much as controlled environment as you can be. And I'm not saying that you guys aren't good at intubating people. I'm sure a lot of you guys have intubated a lot more patients than I have at this point in my career. But just like I said, the controlled environment and the chance to get it the first pass, and limit chest compressions. That's what really is the most important thing, is to limit the chest compressions, and that's kind of more important than the oxygenation even, because those first couple minutes, that's kind of why they stress the compression so much, is you probably have enough oxygen in your system that you're going to be fine without any breaths anyways. So that's, I don't know if that answered a lot of your question, but
yeah, absolutely. I appreciate that. Thank you very much.
yeah. So you're going to stop every 2 minutes for a rhythm check, and then kind of we're going to diverge into 2 pathways again here, the shock versus the not shock. With the shock, you're going to keep shocking them if you keep getting in VFib or pulseless VTAC or VTAC. You're going to shock them, and then after 2 rounds of shocking, then the recommendation is to give amiodarone 300 milligrams. So then you do another round, shock them, and then you do 150 milligrams for your next dose, and then you just continue shocking, and then you think about reversible causes while you're doing this. If you're down the PEA asystole pathway, then you're going to just give epi every 3 to 5 minutes. You're going to do chest compressions, check every 2 minutes, and then think about the reversible causes. If it's not an arrhythmia or a heart attack, then why are they arresting? Because that's ultimately what you need to fix. So classically, those reversible causes kind of break it down to H's and T's, which makes it easier to remember. Hypovolemia, are they losing blood? Are they real dehydrated? So you can always, I think it's always a good idea to give, start a liter of normal saline while you're doing CPR, just because, obviously they're not circulating very well if their heart's not beating. So help them out with that in volume respect. Hypoxic, was this a choking episode? In that case, the airway probably is more important. But it'll probably be pretty obvious if it's hypoxia or if it was, a drowning incident, something like that. Hydrogen ion acidosis, if they, are hyperkalemic or an acidotic, that would be a situation where bicarb might help you. Hypo or hyperkalemia, again, the bicarb with the hyperkalemia. If they're a dialysis patient, maybe they're non-compliant, then you kind of have to think about hyperkalemia in that situation. So kind of just looking at your patient and think about what risk factors do they have to have one of these. Hypothermia, if they're cold, warm them up. The kind of classic saying is, they're not dead till they're warm and dead, especially in drownings. Tension pneumothorax, if you listen to their lungs, and you hear one side's down, then you're going to, stick the angio catheter either in the second intercostal space, mid-clavicular, or nowadays, especially when you have Joplin-sized people, you put it in the 4th or 5th intercostal space in the axillary line, just to relieve that tamponade. And then you get them to the ER, and then they can put a chest tube after that. But that'll stabilize them until then. Cardiac tamponade, that's kind of pretty hard to recognize. You'd probably suspect some sort of trauma in that situation. Toxins, if they've had some kind of overdose, that caused them to go into cardiac failure. Thrombosis, PE, that's also going to be a real hard one to pick up. And that will be kind of the ER giving them TPA if they think they need it. And then coronary thrombosis, so if they have a heart attack, that obviously can make your heart stop in some situations. And then a lot of times after you give them epi and get them going, then they'll have that VFib, VTAC, and then you shock them. And then they're okay for a little bit, or maybe you get Ross back. So just kind of think in your head, why is this patient coding, and is there anything I can do to change it? So ROSC, return of spontaneous circulation, defined as pulse and blood pressure return. If you've got an end-tidal CO2 monitor on them, you see that it all of a sudden bumps up to above 40. And then if you have an arterial line in, you see some spontaneous arterial pressure waves. And then once you get ROS, you go into post-cardiac arrest care, which I know you guys have another lecture on, so I won't really touch too much into that. Just kind of the gist with the hypothermia protocol, if they wake up, they're neurologically intact, then they probably don't need that. But if they, you get ROS back and they're not having any no reflexes or not neurologically intact or have altered mental status, then you'd probably want to think about hypothermia protocol. And then there's, of course, some contraindications to that. Mainly head bleed, and then a few other things, which I'm sure you guys will get in another lecture. So factors to consider when you're thinking about termination of CPR. There's no real hard and fast evidence on this. Typically you start to have, you worry about hypoxic brain injury after, could be as little as 3 minutes, but it's usually, 5 to 10 minutes. If you've been going for over 30 minutes without, any organized rhythm, then your chance of neurological outcome is probably not good. I know they used to use super high doses of epinephrine. One of our docs, who's a paramedic, Dr. McDonald, he was telling us, that he used to give enough epinephrine that he could get a pulse to a rock. So just because you can get a pulse doesn't mean they're going to have, meaningful recovery, which is what our ultimate goal is here. If you have an initial rhythm of asystole, those people tend to do a lot worse, so kind of think about that with your final disposition. If you have a prolonged interval between estimated time of arrest and initial resuscitation, they're probably okay during the first couple minutes without any oxygen, but after that, then they're not getting any to the brain, and that's when you're going to have that brain injury. People do best when they have CPR almost immediately and when it's witnessed. The stats on out-of-hospital cardiac arrests are not very good. Look at patient age and severity of comorbid disease. If they're end-stage renal disease, their palliative care, which I would question why they're getting CPR anyways, but sometimes it happens. Are you really doing a service to them by continuing to do CPR? If they don't have any brainstem reflexes, and like we talked about earlier, if they were cold and now they're normothermic, they're back to normal temperature, and they're still not doing much, then they're probably not going to do well either. This was some sample criteria I saw in a study, about 7,000 cardiac arrest patients in Washington, the state of Washington, at several places, and then it's multi-center. So there were, of those about 7,000 patients, 2,800 met these three criteria, and only one of that 2,800 survived. So if you have these three things, then your survival rate is not good. Arrests not witnessed by EMS personnel, non-shockable initial cardiac arrhythmia, so the asystole, the PEA, and then no return of spontaneous circulation prior to administration of a third 1 milligram dose of epinephrine. So likely those people are getting hypoxic brain injury, they're not perfusing their organs, they're not going to do well. And this is just a sample criteria that this study came up with as, maybe a suggestion of kind of when to lead you to stop CPR. But every situation is unique and has its own kind of circumstances. Okay, so now I'm just going to I don't know if I was supposed to include these in this talk, but I'm just going to briefly go over bradycardia and tachycardia. Bradycardia, the textbook definition is less than 60 beats per minute, but usually you worry about it when it's less than 50 beats per minute and they're, symptomatic. If somebody is just an elderly person or takes a beta blocker, or maybe they're just a cross-country runner in good shape, then they might have a heart rate in the 40s, but that's okay if they're asymptomatic. So if you've got somebody that's bradycardic and symptomatic, you kind of want to do all the things you guys know how to do. Give them oxygen if they need it, put them on the monitor, look at the rhythm, get IV access, and do an EKG if you can, if they're stable enough. So you kind of want to make a decision are they stable or unstable? And those unstable things are kind of in that red box there. Are they hypotensive? Are they altered? Is their blood pressure real low? Do they look like they're in shock? Are they real cold extremities or real warm extremities? Are they having chest pain? Do they look like they're real fluid overloaded? You know, do they have crackles and 3+ pitting edema? So if those things aren't present, then you can kind of just observe them, keep them on the monitor, get them to an ER and kind of have them worked up further. If they are unstable, then the first line therapy would be atropine. And you got to remember with atropine, it's not necessarily going to work with Mobitz type 2 or complete heart block. Is that okay? Okay. So you give that 0.5 milligrams or 1 milligram once IV, and then you can give that every 5 minutes up to 3 times. Next, if the atropine doesn't work, you can consider transcutaneous pacing, dopamine, or epinephrine. At that point, you just kind of want to get them to the hospital, and they'll get worked up further from there. Here's what the ACLS bradycardia guidelines kind of say about the dosing. They say 0.5 milligrams of atropine, repeat every 3 to 5 minutes, maximum 3 milligrams. There's your dopamine infusion and your epinephrine infusion. And you're going to want to titrate those to patient response. Tachycardia, again, the textbook definition is greater than 100. We're kind of worried about greater than 150. Again, get them on the monitor. If they're hypoxemic, put them on oxygen, get their blood pressure, and you want to figure out, are they stable, unstable? Do they have hypotension? Are they altered? Do they look like they're in shock? Are they having severe chest pain? Are they fluid overloaded and heart failure? If they're unstable, you kind of the first response is always to shock them. Is this rhythm causing them to be unstable? Then you need to fix the rhythm. And the answer to that is synchronized cardioversion in most cases. A lot of the times, if they're unstable, it'd be nice to give them, a tiny bit of sedation, maybe a little bit of Versed, but depending on their vital signs and what they look like, you might just have to give it to them right away. So from there, the stable to unstable, the next thing I kind of think about is it wide versus narrow, which we talked about a little bit earlier. Is it greater than 3 small boxes, the 0.1 seconds? So narrow would mean it's most likely above the ventricle. So then you'd want to do... Sorry, we'll get into the next slide, I guess. With the shocks with the unstable rhythms, there's different joules there for different things. For the narrow regular, they recommend 50 to 100. For the narrow irregular, so that's probably more AFib, that's 120 to 200 joules. For the wide regular, 100 joules, and the wide irregular, 200 joules. And the wide irregular is not going to be synced because there's not really any P's or Q's to sync things up on. So you're not going to worry about throwing them into a ventricular arrhythmia. They're already in one. So here we talk about kind of the wide versus narrow QRS. If it is wide, then you're going to want to consider antiarrhythmics, and this is if they're stable. So if they're stable and it's wide, then you're going to want to consider antiarrhythmics like amiodarone. If it's not wide, then the first thing would be vagal maneuvers. You think about bearing down, you think about a modified Valsalva maneuver, which is pretty easy to do and has a lot more success than the regular Valsalva maneuver. typically what you can do is just take a 10 cc syringe and have them blow into the syringe as hard as they can while they're sitting up. And then just as they're about to run out of air, you just lean them back and lift their legs up. And then just leave them there for a little bit. And that typically works pretty well. The ER physicians at Freeman typically report like 75% success rate on that. So it works pretty well. If that doesn't work, then you can do adenosine, and then typically a calcium channel blocker or beta blocker, and then just, if that doesn't work, just get them to the hospital. The recommendations for the medicines: adenosine is going to be 6 milligrams, followed by 12 milligrams, and then another 12 if you need it. Cardizem or diltiazem is typically 20 to 25 milligrams one time. And then for those wide complex arrhythmias, you're going to give procainamide, amiodarone 150 milligrams, and this is if they're stable. Solol 100 milligrams. You could try bicarb. And then there's one situation where you would give magnesium, which is going to be 2 grams. And that's going to be when you get this torsades, which is kind of it's a regular ventricular arrhythmia, where you get that high voltage followed by low voltage, kind of oscillating like that. And the treatment for that is magnesium, 2 grams IV push. And I think that's all I got. Hopefully you guys picked up a few things. It was a good review. We'll take a look at the chat if you guys have any other further questions.
Well, perfect. Do you have some time for a little bit of roundtable discussion?
Yeah, sure.
Absolutely awesome. Okay, so this is a subject that is kind of near and dear to our heart on the fireside. We are our goal as a Joplin Fire, and we have met in Newton County. We have several entities involved with this, and I've said this in our live classroom on the last Wednesday. Our goal is to ensure an excellent base level of service that our ALS providers can show up and build upon, because I think that that foundation is there, and lets these guys do all their other skills and fun tools that they have. So what we have looked at is we've looked at really drilling compressions.
Mm-hmm.
And that has become something that, one, we practice on, but two, we actually have grade reports that go out from the monitors. The monitors kicks out a compression analysis of depth and rate and release velocity and all those metrics that the AHA looks at. So, as we move forward, and that's when I kind of talked about the iGel briefly, because there's been a little bit of discussion going on in the forum about iGel versus innovation and this, that, and the other. When you're working, typically, let's say you're working in the city of Joplin, you're probably going to have 4 EMTs show up for one of my trucks, and then a paramedic and EMT off of an ambulance. There's a lot of things happening for a paramedic to say, okay, I need IV access, I need this, that, and the other. I need to be working ACLS. I need to be looking at a defibrillator. There's a lot going on in a very short period of time. So what we've tried to do as an agency is to pull back and say, okay, what can we do to take stuff off your plate? What can you pass us that we can handle on our level of service? And we do have ALS engines, and those guys are excellent. Our ALS personnel do a great job, but we don't have the personnel to put one on every truck currently. So with all that said, we've leaned heavily on the iGel, and I know that just kind of goes back to that discussion of, we want that patient, we look at, we actually have an iGel protocol. We also have a pit crew CPR guideline to where our crews have assigned positions, just like the first 2 minutes are almost scripted, if you will, where we grab the patient, we pull them to the living room or whatever the most open area is that we can get personnel around them, and we get a guy on the chest immediately. That's the first thing that happens. The other patient or the other personnel are removing clothing around the compressions or putting pads on around the compressions. There's somebody at the head that's pushing the iGel. to the point that we don't even grab the mask part of the BVM. We go straight to the eye gel to keep the air. We want it in the lungs, not in the gastrointestinal tract.
Mm-hmm.
So that's where we're headed. The fast compression. We kind of look at it. We've been taught to the hurry is to get on the chest.
Right.
Everything else is secondary, and sometimes it could be argued that's even effective. Everything else was secondary. What would you say? And I am not trying to, by any means, delineate or talk down other levels of service, because now I'm a paramedic myself. I used to, I love to intubate. It was something that I would, I practiced, and I thought, we all think we're really good at it, I guess, but I thought I was really good at it. And I know that kind of takes that something, not that we don't ever want to take anything out of our toolbox, but it puts it at a point where, well, should we even be intubating anymore? And there's discussion on, what areas, what should we intubate and what should we not. And, I think what we're saying and what you're saying is about the same thing. It's the definitive airway.
Mm-hmm.
An iGel is not a definitive airway. It's a great airway, and there's all kinds of clinical studies about how great it does. However, as a paramedic, I want to reach down and I want to say, I have the airway in my hand.
Mm-hmm.
I know what I saw it placed. I got return, I got condensation, I got capnography. I know what I have. But now that things are changing, it's almost as it becomes a secondary or even a third down line of procedure to where they do have an airway. It is, I got chest rise, I got easy bagging, I got capnography return. I think I'm going to leave it alone for, so I can get my IV, I can get ACLS drugs on board. I can get a rhythm that's really good and shockable. Then I can look at, well, maybe I should intubate now. Or maybe, hey, listen, I'm happy, we're getting somewhere, let's just go. What are your thoughts on that process, and where do you see the future going? Because I know it's always a changing, moving target, but 20 years ago when I came on a truck, we were riding the side of the cot doing compressions, going into the ER and stuff like that, and we found out that was horrible. I mean, we didn't have feedback at the time. We were doing crappy compressions. We were off the chest for a long period of time trying to intubate. We were creating more intracranial pressure by pre-oxygenating and bagging the crap out of it before we went to intubate.
Yeah.
Now all that stuff has been contraindicated. So, where do you see the next step of things going, and what would be your 2 cents versus, I don't want to start the argument of BLS versus ALS, but I think it definitely needs to be talked about BLS before ALS.
Yeah.
To get that set of skills going and get that patient, it's compression.
Yeah. Well, the AMA's, stance now is it's always been, you've always kind of thought of it as like a ABC, but now they've changed it to CAB, where the circulation, the chest compressions are the most important. And I think if you get the chest compressions, you get all those other things taken care of, and they're easy to bag, or the iGel just goes in quick, and you have all that other stuff taken care of, then I think that's not a problem, to go ahead and intubate the patient. If you have all that other stuff going and you're still on scene and waiting, till you can transport the patient, because it is definitive airway. But I don't think it definitely shouldn't delay other things. And you want to do it when you're, in between that 2-minute time when you're checking, or if you can do it while they're still doing compressions, that would be ideal. You just don't want to stop compressions to do something that they can do at the hospital, without those interruptions and in a more controlled environment. Like I said, a lot of you guys have probably intubated more patients than me at this point, so I feel kind of awkward talking about that, but I think you guys do a great job. I think just the kind of limited evidence, again, there's not like a lot of really great randomized control trials and things like that based on airways and that, but the few that I saw, it's either similar survivability, I think just because, this is an event that not very many people survive just in general, but either that they're the same or maybe slightly better for the supraglottic airway, just because, in that situation, usually you're going to get the airway 100% of the time, and where if you intubate somebody, like, even if you're super good at it, 98% of the time you're going to get it, so then there's always that some chance that you're not going to get it. So I think if you have everything else taken care of, or you've got a lot of people that you can concentrate on that one thing, then I think that's perfectly appropriate. You know, that's what the patient needs, and you guys are appropriately trained to do that. Just kind of have to take a look at the whole situation every time.
Oh, absolutely. I honestly, personally, 100% agree. You know, if everything else is working really well, or you have extra personnel, but don't take away from a known, we have to have it, which is compressions, to get a maybe of I could have a little bit of airway. So that's very interesting. So, well, I appreciate the time to answer. I'm gonna look real quick to see if we have any more questions on the computer real quick.
Yeah.
Okay, I believe that's all the questions we have right now.
All right.
Doctor, thank you, sir, very much for coming out.
Yeah. Thanks, guys. Appreciate your time. And don't be afraid to ask questions or anything. Always happy to teach.
All right, I believe Mr. Prosser is going to come in here in just a moment. I may be talking out of turn because he's in his office currently.
We're going to take a break, so we might just tell them those.
All right, we are going to take about a 20-minute break. We're going to get everything reset for a next session. If you're watching live, remember it's going to cut out for just a minute. You're going to have to re-log in. Otherwise, I caught myself watching some kind of Spanish soap opera earlier because that was the next in the queue on YouTube. So, yeah.
Your favorites list.
Yes, please don't do that. I have no idea what they're talking about. So, yes, about 20 minutes. Get back logged in, check in, let us know you're here, and get some great questions going. Let's start a good discussion and